both Tom and Amy have actually talked about the incidents, right? The statistics that describe people and youth with issues. You raised something really interesting when you and I were speaking earlier. You talk about the difference between reactive care and proactive care. A lot of what we're talking about here is there's an incidence of an issue and we're talking about how do you get treatment as quickly and as effectively as possible. I'd love to hear you talk about what proactive care means.
Sure. So one of the really nice things of the Affordable Care Act was this accountable care organization model, where Medicare said, look, we'll attribute this many lives, patients to you. You figure out how to do three things. Number one, increase the quality of care that they achieve. Number two, improve the experience of care they achieve. And number three is make the healthcare more affordable than what our projections look like it's going to cost. So 3 targets. You're given the ability to decide how you wanted to do it. So, of course, we looked at our physicians, and we had very strong primary care presence. And the beauty was, as part of this, we got all the data. We had all the claims data from the insurance companies, from Medicare, our EMR clinical data. We made sure we obtained that, lab data, pharmacy data, social determinants of health data, every bit of data we could. Built this large AWS cloud-based platform. And all of a sudden, we opened up our eyes and said, wow, number one, we're not as good as we think we are, because every doctor you talk to, oh, I'm the best here. It's that other doctor that's ruining our numbers. You know, our performance isn't good because of them. You know? So it allowed a lot of transparency among us, you know, humbled us very much and said, oh, we have to be better. So that became our motto at the beginning of this 10 years ago, was we will care better. We're going to help our physicians and providers care better for their patients. We're going to help patients care better for themselves. And we're going to help people care better for each other. So that has guided us over the last 10 years. The problem is we've always had a top-down delivery system here in healthcare. And we said, no, we're going to flip that upside down. We're going to start from the patient up. And we realized that if we could, especially through our data, could understand our patient better, we could actually not only treat the diseases they have, but maybe prevent the disease. And if you want to have the most cost-effective, best patient experience and great quality outcomes, that's where you go, proactive care. So that's what we really based everything on, is really knowing the patient better. Now, that took a big change, because when I was taking care of patients in my practice, family practice, and you go in the office and you're into the examining room. Oh, hi, Mrs. Jones. How you doing today? Great, great, great. I got my back pain. Oh, doctor, let me show you the things I got off the internet. I got to go. Oh, God, I got to look through this list. And you get through whatever you can, and then you think you've wrapped it up. And okay, I reacted to everything Mrs. Jones wanted me to, and I'm out of here because I'm already running 30 minutes behind. I got to get to the next examining room. I get paid on a number of patients. I got to give loop. So you grab the handle on the door, you're ready to go out, and the worst thing that could happen to you as a doctor, you hear the patient say, Doc, one more thing. I'm like, oh no. It's like, Doc, I think I'm depressed. And you're like, oh, damn. It's like, this means I got to come back in this room and spend 5 to 10 minutes with this patient. But no, what we had, the managed care companies, is 1-800 mental health on their insurance card. Here you go, Mrs. Jones. Here's a way that 1-800 number. They'll take good care of you. Boom, I was gone. So that was not good care. That wasn't proactive care. That wasn't understanding, listening, anything. So we really realized it, and as we got into it, we realized that the behavioral health diagnoses were 3 times higher cost, no matter what disease they had. It was a 2 to 3 times increase in cost because they wouldn't take their medicine. They wouldn't take care of themselves. So we got very, focused on the behavioral health component and how do we make a difference with that. And that's kind of where it led us down the path of behavioral health.
Tom, maybe you can continue on this topic. So clearly, Jim, as I understood it, right? Lots of benefits for proactive care, but the way the economics of the healthcare system are set up, there are all these disincentives for medical professionals to make that diagnosis or spend the amount of time they need to with a patient who may, at some point in the near future, be in need. Tom, can you speak a little bit more about that or any other issues that can impact providing lesser proactive care? I mean, that seems like the most logical thing to do, and I'm not really in the field, but right, hidden before it kind of evolves, right?
Yeah. No, absolutely, and it is really striking that when you go to medical school, there is a belief in following an evidence base. There's a belief in following the science. And then when you start to practice medicine, what you find is there's often an inverse correlation between the expectations that physicians are placed under in a fee-for-service world, in our what's called a relative value unit, I know you know all about that, Jim, where physicians are essentially paid to a large extent based on how productive they can be. And it's very hard when you're constantly seeing patient after patient after patient to ensure that you're providing quality care. And the other consequence is that physicians are getting increasingly burned out. 50% rates of burnout among physicians. So you're providing care where you're feeling more distant and detached, or getting a lot less satisfaction from the care, and everyone suffers as a result of that. So that's one aspect of this. Another is that with psychiatric illness, a lot of people don't recognize it. There are different ways that psychiatric illness present. I will never forget, in my residency, a very long time ago, I was meeting with a young man who described having a hollow feeling in his stomach. The gastroenterologist had no idea what to make of this. He'd had extensive workups, no idea what was going on. All the tests were negative. And I met with this man for a number of sessions, and it became very clear that this was a proxy. This was his way of saying he was depressed. He didn't identify it as depression. And in fact, once the depression was diagnosed, once he received treatment, that hollow feeling in his stomach that led to a cascade of tests, some of which had adverse consequences for him, stopped, and he got better. And he was able to get out of this cycle of revolving care that was leading to nowhere for him. So proactive care really means being able to surface the underlying psychiatric problems, which fuel so much of this excess utilization, a lot of suffering, both medically and psychiatrically. And Jim, I just want to pick up on one thing that you said. It's true that patients with depression are less compliant, not because they don't want to be compliant, because there's apathy and so on, but there are also pathophysiologic links between psychiatric illness and medical. I used to write on panic disorder, and I would never want to show my patients my publications. I would talk about how, in fact, panic disorder can lead to ventricular arrhythmias and sudden cardiac death, and there's a whole litany of physiologic explanations. Why, for example, when you look at cohorts of patients after they had a heart attack, how many patients 6 months out in the cohort that are not depressed do you think are deceased? 3%. If you look at a cohort controlling for all sorts of risk factors, body mass index, how well the heart is functioning, ejection fraction, a whole range of things, what percentage of patients 6 months out with depression, control group, are deceased? And want to guess? 17%. So a dramatic difference. So it does have to do with compliance with cardiac rehab. It also has to do with differences in heart rate variability, in how the microvasculature in the heart works when you're depressed versus when you're not. There are a lot of factors. Platelet aggregability, how sticky the blood is, and how more likely would I get a stroke, a whole range of phenomena. So if we don't treat the underlying psychiatric problems, there are a slew of medical problems. And so proactive care means surfacing, means identifying, means screening, means identifying those kids when they're young, so there isn't this 8-year lag between the onset of symptoms and initiation of treatment, which then leads to truancy, which leads to lower socioeconomic attainment, which leads to drug use, a whole range of phenomena that well established. We go out there, we screen. Screening is not just giving a pen and paper test. It's not just giving someone a scale, whether it's through advanced technology or not. It's much more than that. But we have to come up with ways to combine the ability to proactively reach out to patients through technology. I think that plays a role, through human beings and the relationships. We were talking, Amanda, about the importance of relationships between care team providers and individuals struggling with all sorts of illnesses. And the combination of the two is truly synergistic. So a lot of work needs to be done to fix our system, but we can't just wait for patients to come to us. And the reality is this notion of evidence-based care, measurement-based care, what I was saying earlier, it's an illusion, quite frankly. I mean, it's not an illusion in the sense that it doesn't exist. There's an evidence base out there, and it's not an illusion that we don't understand the importance of it, but it's an illusion when you look at how medicine is being practiced in most places most of the time. Most, you guys disagree, if anyone in the audience, but the reality is if you really look, how often is measurement-based treatment to target care, and specifically in behavioral health, being practiced? And I will tell you, having done this a very long time, it's a very, very small percentage of practitioners who are actually engaging in that care. So how do you even know if patients are getting better? It's a real challenge. The reality is we have technologies that do that. We have a science that does that. The problem is we have a workforce of physicians that are very burned out. We have a lot of inertia. So there's work to be done, although I am hopelessly optimistic, actually, about this, because I think it's an exciting time, but we have a lot of work to do. So
we're gonna come back to the tech angle in a second, but I wanted to go to Amy to talk about the application of proactive care in a university and community environment, right? What shape do you feel that takes? What should universities be doing? Is there any university or community organization you know of that seems to be doing at least a few things really well?
Well, I think every university is a little different. I'm not in counseling, so I can only speak from, what I know. So at Drexel, we have peer counseling. I have my notes. Suicide training. We have different wellness lounges across the university where students can go and either have a quiet space or just a place to relax and chill. We're training faculty and staff not to refer every student, rather to show empathy towards the student. We try to accommodate as many students as possible using a flexible model and try and be as inclusive as possible. Drexel is very diverse, so we try and be as inclusive as we can.